afternoon, everybody, to this webinar. I repeat myself once again. Don't forget to mute yourself. I will try to unmute a lot of you if it doesn't work. But welcome to the Quality and Safety Network. For those who it's the first time, I will briefly explain what we do and how many years we've already been active. We have created with HOPE, the European Hospital and Healthcare Federation, these webinars that have been issued since 2019, if I'm not wrong, just to try and share best practices and experiences, because it has been one of the ways to improve our health systems, and most importantly, to share about how we improve quality of care and patient safety in our own countries, and that we can share with others. Like I said, we've been hosting these webinars since 2019. You have here an overview what we've been doing, increasingly giving webinars and countries the opportunity to share their experiences. In 2022, we also had 4 webinars, and today is 2023, and it's the Danish experience that we'll put in the spotlight today. Just to remind you, all those webinars are available online for you to review. Presentations are also available, and you can always contact every speaker if you have more questions about what they talked about. What's next? Well, we'll keep in touch about the program that will be addressed to you for 2023. So if you're interested, just keep reading my emails or getting the HOPE newsletter. You'll be informed. Today we're all from Europe, even outer Europe, so that's interesting too. We had 22 countries represented in the registration list. We do have a lot of people connecting in, so that's.
And Wednesday.
Please do mind to mute yourself again. Don't worry, I just heard somebody, so practical reminder, mute yourselves. But furthermore, thank you for joining us. Today, like I said, it will be the Danish experience. We have 3 speakers joining us today. We have Erik Gilling, sorry for a pronunciation if it's wrong, who is the Executive Vice President of Health Politics at Danish Regions, so an umbrella organization of 5 regions of Denmark. We do also have Inge Christensen, a Chief Executive of the Danish Society for Patient Safety. And then we also have Mr. Kim Gard, who's a Chief of Quality at one of Denmark's largest hospitals. I won't pronounce the hospital, I will let you do that. But we do have 3 quality speakers, a quality webinar also. So here is their teams. I leave you the floor.
Hello everyone, my name is Erik Gylling. I'm Executive Vice President in Danish Regions, and Danish Regions is the interest organization for the 5 individual regions that manage healthcare in Denmark. We have a regional healthcare system. Beyond that, we have the government, the state, who make the legislation, the patient rights, and we have the municipalities who has the responsibility for pre-care, for prevention, and for rehabilitation. I'm glad to have this invitation to take you through our quality journey in the Danish healthcare system. We had from the beginning of the 2000s a blended quality system in Denmark. It was composed of some parts of joint commission system, some parts of the Scottish quality system, and some part of a Danish invented system. But this common system was covering the quality improvement and the quality control area for some years in the beginning. We had the experience that the surveyors did a very good job. We had some qualities about this accreditation. We got standardization. We got leaders focusing on quality, and quality got up in the agenda. But at the same time, it was a very troublesome work The first round of surveying was very good in giving us exactly those winnings that I present here. But at the same time, the expression or the impression was that it was very troublesome. We made a lot of bureaucracy in having this accreditation, and it moved sort of away from the front line. Therefore, in 2015, we had negotiation between the 5 regions, with the government and with the municipalities. Shouldn't we invent a new quality system, a quality improvement system, where we very much focused on guiding principles for a quality program? It is a shared program. We are looking at the overall qualities in the healthcare system, expectancy of life, etc. We are looking at the patient journey from cradle to grave, and we are looking at the quality impacts that we make on an institutional level, wherever it's in a municipality, in a department, in a hospital, or in a general practice, for example. The very important thing was not to pick down on control, but to look at improvement. So we sort of moved our focus from the quality control system to a much more quality improvement system. And we are trying to subsidize that. As I said in the beginning, this is very much a journey, and we'll never finish the journey because we are still improving also the model. So for the moment, we are talking very much about moving from a quality system to moving to quality principles in the way we behave and in the way we plan our healthcare system. Our philosophy is this model that you probably know, the system for improvement. You will always have front runners, researchers that tries in the edge of development to improve things the best, and the majority will sort of follow after. And that's the main task, is to get the system to follow after the front runners and to implement. And of course, as you see in the red area, we'll always have bad apples in the system. And of course, we have to do something with that, educate them, or simply take them out of the system, if that's the case. We put down some tools to make this system change and to make the cultural change into this improvement philosophy. And the demands, as you can see them here, is we have to implement the best practice quickly. We have to catch up all the time. Evaluate what you're doing, evaluate your results, spread them, and catch up. So we always have the get behinds to catch up to the level of the others. You have to improve or implement the quality or the culture of learning from each other. Share your mishaps, share your disasters, and learn from them to improve. You have to work systematically, and you have to use real-time data. Having a report of how your practice was a year ago or 2 years ago is not quite motivating for improving. And you have to have the leaders to drive this improvement. They have to make the safe environment where you can work with these matters, and you have to drive as a leader forward the quality improvement. It should be quite as important for a hospital manager as looking at the bottom line. The quality for the patient must be top of mind. And you have to have confidence to your care professionals. Believe in them. Believe they are in the job to do the best thing for the patient. And we know also from our COVID experiences that the purpose is what drives people. We also wanted to have not only beliefs, but facts. We want to put data behind what we're doing. So we are leaning or stepping on our 85 clinical quality databases in the healthcare system. We have a governmental databases concerning the whole healthcare system. We are taking data out of them, and we are quietly introducing a more heavily use of patient-reported outcome measures and pro data concerning satisfaction, etc., etc. It's a more troublesome way to walk, but we are very determined that we want to have pro data or patient-reported outcome data much more solid into this system, because it's also a part of a value-based healthcare system. What matters for the patient concerning quality, concerning improvement, concerning safety. To measure what we're doing, we put up 8 national goals, and those goals should each of them represent the whole patient journey in a national level, the patient experiences in a local matter, and also quality on a institutional level. And if you can see it on the screen, there's indicators beyond every national goal that we have. We have for the moment around 25 indicators, and we have a shared vision between municipalities, the government, and the regions that we will not have a great amount of indicators. We saw that in the Danish quality model, where we ended up with 275 or something like that indicators. We don't want that. We want to keep it in a simple way, to keep it in a few indicators that we actually measure constantly and share them with the professionals in a real-time basis between regions 4 times a year, and in a national level 2 times a year. And as you can see, it's a little inconstant where the indicators are, because we also realize that when it comes to cross-sectional quality, we need actual figures. We doesn't have all the figures we need from general practice, for example, or from municipalities, from nursery homes, etc. But we are still improving day by day in having that as a catch-up. Some of the indicators are very keen or very specific quality data. Other data is much more service provider data. We have a patient right in Denmark to have a diagnosis within 4 weeks, or to have a treatment within another 4 weeks. And we are measuring because we think that is also a part of quality, to have your treatment or your diagnosis in a suitable time. To subsidize the program, we introduced different factors. The national targets I already spoke about, but we also introduced a way of working with quality. We called it learning and quality teams. But the fact is that we want people to work in collaboratives. We want them to define what quality do we actually have, measure it, even in a napkin. Discuss with yourself, where do we want to get the quality? And make a deal about what kind of tools do we have to drive quality. This could be done in a morning conference in a department, or it could be done like we did with our learning and quality teams on a national level. We had experts to define the levels we wanted to improve to, and we made collaboratives between municipalities, hospitals, general practitioners, cross-borderly to make the improvement actions happen. We also made a national leadership program. I'll come back to that. But just to illustrate the learning and quality teams in a scheme, what do we actually do? We want to have systematic improvement work. We want to involve patients, pro data, and we want to have local adaptation. Not just take the national things and drag them down into the local, but have a realistic discussion locally about where are your quality issues. And therefore, the national goals we measure on a regional level or a municipality level. We do not dig quite into the different departments, but we expect that on a regional level, they will take the step to discuss with departments, discuss with doctors, how do we improve the practice that we have here and adapt to this quality improvement model. Experts are, of course, peers, and peers that is recognized as being some of the best in the country. Just to give some examples where we started this, and you'll see I think we have done 8 learning and quality teams until now, typically 6 months to prepare, and then a 2-year bundle to improve or to implement all the things that should raise the quality. We have done that in palliation, in stroke, in antibiotic therapy, in hip fracture patients, ADHD, perioperative treatment with high-risk patients, with abdominal catastrophes, and with type 1 diabetes. The feedback we had from those quality teams is that even if it's a huge work to do, they meet each other in sessions and seminars, etc. I can just tell that the regions in a top managed level are very happy with this work, because they feel that it's in the hands of the professionals and they take ownership to implement what they define themselves to be the best practice, and of course governed by the top management. So we try to now to fold it more out, to make it be a more common way of working everywhere in the healthcare system. Think in collaboratives. Think in what kind of quality do you have. Think in what kind of quality do we want to have, and how do we get there? And when you are there, how do we get further on? Leadership is the key, as you can imagine. How do we actually implement the good thoughts that we are spreading? It's of course a challenge, but it's important that leaders, managers who walk around in departments and other part of the healthcare system to measure how does it work, how is the climate, how is the environment, how is the temperature in the department, that they see quality improvement quite as important as measuring the bottom line. How are we doing with our finances, etc. They should go meet their leaders and ask, how is your quality today? What are you working with? How do you improve what you're doing? That's very, very important. And of course, it's essential to be patient-centered in this work. Visions for the future. We want to spread this even more, to engage patients even more than we do today in defining quality and how to get there. Empower patients to take part of it. We want to, as I said, change from being a system or a service to a guiding principle for the way we work with improvement in healthcare. We are still fighting to get real-time data in every aspect, to have this as realistic and as present as it ever could be in our work. And we're still very engaged in getting the whole journey to work. So it's not only for hospitals, only for municipalities, but we take part in the patient journey from the first meeting with the general practitioners in the healthcare system until they are back in rehab after a patient track. Last, quality improvement has many phases, as you can see here, and we are, of course, bringing everything on board to make this journey be as successful as it could be. Thank you very much.
Thank you very much. I am Inge Christensen. I'm the CEO of the Danish Society for Patient Safety, and I'm very thrilled to be here today to talk a little about the patient safety journey, which of course has been parallel to the quality journey that Erik has just talked about, and it's very fruitful to have patient safety so embedded in the quality program. So I will talk a little bit about the Danish patient safety journey today. I will dig deeper into this figure as we go along, but we have seen a development where we have reported adverse events and so on, and going to this learning system and quality improvement system that Erik has just told about. But what we are really proud about around the patient safety work is that Denmark in 2004 got the first legislation on patient safety in the world. And it is very important, and the principle is well, still here today, that it's a non-punitive system where people, healthcare professionals, are obliged to report adverse events, and that we can learn from them. Hospitals are obliged to act, and the Board of Health is obliged to communicate. That was the case in 2004. Then in 2010, we got the rest of the healthcare system on board, you could say. The legislation was expanded to municipalities, to local communities, and to the patients and carers as well. They have a right, not an obligation, but a right to report adverse events. And still this non-punitive system. This is the development in the reporting of adverse events. As you can see, there was quite a steep increase in the reporting, but it really grew when we got the local communities and the patients and carers to report. Sadly, we don't have as many reports from patients and carers as we would like to, but still it's a possibility, and this system is growing, and now we have more than 300,000 reports every year to work on as a basis for our learning system. The early years for patient safety, you could say that those problems still are relevant. But we started along with safer medicines, labeling with some of the high-risk medication and so on. And well, still today they pose a risk, but we have learned a lot from that work, and some of the things we actually have got rid of. We have had, in Denmark, we have had an emphasis on learning from others. This is a picture from some of our Scottish friends. We have learned a lot from the Scottish patient safety program. We learned about bundles. Erik used that phrase also in talking about the collaboratives. So these things are embedded into each other. We learned that improvement work really is what we have to work very rigorously with to ensure that the things we decide are actually implemented. We learn to work with data, statistical process controlling, and so on, driver diagrams, etc. That resulted in a large program from 2007 to 9 called Operation Life, very much inspired by some of the American experiences with Don Berwick in front. And that has had and still has some impact in the way we are working with patient safety, using campaigns, having very bold goals, and so on. The Safer Hospital program ran from 2010 to 13 with 5 major hospitals in Denmark, and they learned a lot about being close, the importance of leadership. On one of the pictures you can see one of the chief executives of a hospital attending a board meeting, and that's what they're really doing, being present in the among the professionals, among the staff, and working with data, and also learning about how results and this work can actually create joint work. We expanded this to a national program for safe delivery, had a reduction of newborns with asphyxia as much as 48%. One of the actual things that we have actually had a peer-reviewed article about, which is too rare in this work that we really have that. Yeah, you can see the reference here. We moved on to mental health, and as you can see, we had some significant results. This is just examples. It was a 4-year program, and it was also nationwide, and really significant results that are used even today, and the methods are used today. We moved on to the community settings. Healthcare is moving into the communities, and a lot of work has to be done to really work with patient safety culture, to work with the quality structure in the communities. So we have been working up until now with around half of the 98 municipalities in Denmark. And these are some of the results. I regret they are in Danish, but this is about medication. We have had units that have had 700 days without medication harm, and that is actually quite fantastic. Pressure ulcers has also been one of the bundles that has been worked systematically with. We have some units with more than 600 days without pressure ulcers, and we can actually say that in the units that have been a part of this program, pressure ulcers are effectively eliminated. Service users' involvement in care is very important in this work. We have to use the patient voice to get further, and this has been embedded in some of the work and has shown significant results. But we can do, as Erik also said, we can do even better in this area. The current debate on workload, performance management, of the professional cultures, is of course also important to the work of patient safety. And also there is a snake in paradise in some of this work, and you could see in the journey we from the beginning we ended off with the question whether we are going in a proactive or reactive direction. And I'm sure that we are very keen to pursue the learning system, but we also have had induced some quite fierce control mechanisms from regulators, and we can actually see that this is taking its toll on the healthcare staff. So it's important, as Erik also said, to build capacity and to do so on the basis of the model for improvement. That's sort of the motor in all this work. It's also important that we go from the triple aim to the quadruple aim. Patient safety is a moving target, and what we can see is that we really have to have a focus on staff, not of course solely. We don't want to lose or to miss the patients, of course we don't, but we do have to have much more focus on the well-being of staff. So going from a triple aim to a quadruple aim will be very important in the future. So it's important to create vision and to build will around this work. It's very important to develop capability and capacity to do the improvement work. And it's also very important to deliver results. You can't motivate anyone if you don't deliver real results like the ones I've just shown you. So it's around people and driven by people and the communities, and it should engage across boundaries. And that's, I think, one of the frontiers we are seeing, and that one of the things that we really want to do is, as Erik mentioned, much more emphasis on the cross-sectoral work. So yeah, nothing happens if we do the same thing all over again, but we have the tools and the means, and we have the will to do things right. So I really think that we can show you some very nice work when you hopefully come to Copenhagen in May to join us for the International Forum on Quality and Safety, which will be in Copenhagen.
Pode
in
nos
May.
enviar
Thank you very
e-mail
much.
para o nosso e-mail.
Okay, so I think you're through with your presentation. We can go over to questions and exchanges and discussions. There's no question that's popped into the chat except the technical issues. But I do have maybe one question just to start the discussion. So it's been 7 years. What about the next years? Oh, I see somebody has a hand raised, but I'll give you the floor after it, Taylor. But maybe in one sentence, what's next? What do you see about quality improvement in the next 10 years, maybe?
Try to answer that question. I would say that the transformation, the digital transformation of the whole healthcare system that we need to do, if we don't want to do it, we need to do it because the double demography, as we usually speak about it in Denmark and in other countries, is so dramatic that we have to change the way we adapt to the healthcare system. We have to put some of the big chronic diseases out in the primary healthcare sector. We have to empower people to take care of themselves, and we have to subsidize that. So hospitals is reduced to some kind of residual. And that, of course, gives challenges as well to the improvement system. And our challenge is that we have a lot of data in the municipalities and at general practices today, but they are not stratified and they are not sort of what should I call it, washed, so it could be structured and used for quality improvement in a more systematically way. And we have to do that in the upcoming years. And we have, fortunately, we are agreeing on that cross-sectional. So that's what we are aiming at, that we have a much more homogeneous travel journey, not just concerning hospitals, but everywhere in healthcare. We have to learn lots more about prevention and what is happening in people's habits, and link it together with the quality system. So that's what we are hoping to achieve.
So more of an integrated system of the healthcare system, the integration.
Say that I said a little about the importance about leadership, and we actually have a leadership program. We had that in the first 4 years. That was very traditional, getting people into having some courses, give them some tasks, and try to work with quality and go home and spread the good news. Now we have sort of taken a second part of that improvement leadership program, where we have engaged much more directly hospitals, municipalities, etc., in creating an interactive program where we could educate 4 times as many, and we could give them tasks that are locally based. We have reorganized or are reorganizing our healthcare system, as you can hear from my speaking. So we have a much more narrow collaboration between hospitals and municipalities and general practitioners. We are creating what you, at least in UK, also know as health clusters. And within that health cluster, there's a lot of improvement work to be done, and to be done in a collaboration, and to be done with a very strong leadership in front of it.
Thank you. I will then give the word to Taylor Orkson.
Hello, thank you. Can you hear me? I'm actually driving, so.
We can hear you.
First of all, thank you so much. It's so inspiring to listen to you. Even though, I've heard and seen the Danish story quite a few times over the years, it still surprises and inspires every time. I have actually 2.5 questions. Great to see you, Inga. Why do you think that, my first question is, why do you think that the Danish were the first? What is your kind of magical key, or the element that makes you these fourth runners? And in addition, if you were to compare yourself for the other fourth runners, for example, Scotland, like what is it that makes you succeed? And my second question actually comes from the last answer to Mr. I can't see your name because I'm driving. Anyways, and my second question is about the leadership program that you were talking about. If you could just elaborate on that a little bit more. Thank you.
Thank you, Tilly. I think that Erik is actually going to answer both questions, because he was operational in the creating of the Danish Society for Patient Safety, and being the CEO, it's of course a little megalomaniac to say that we were instrumental in that. But I think creating a society was actually quite important. And then we had the right partners. Erik was at that time, he was a younger doctor, very young still, but younger doctor. He was very engaged in this work. We had a lot of others from all over the system who are actually still behind and engaged in the Danish Society for Patient Safety. And we had some quite visionary politicians at that time. Actually, they are in government again, so we hope that they can help us with the new problems we're facing. So it was a combination of things, but a very strong focus at that time and a very strong indignation about patient safety actually certainly drove some of that development.
Thank you, Inge. I think I'll actually pass the word to Kim Garde, who could answer as well as I can about your questions.
Hello, I'm Kim Garde, Head of Quality in Copenhagen University Hospital. I'm also a physician, and the idea of the patient safety system was very appealing to all doctors. I think that it sort of is part of a practice we used to have to discuss these things that nearly or went wrong. So I think it appealed a lot to a significant group in the healthcare system, the doctors, who's traditionally been a little less dedicated to classical quality work. But the patient safety area was very appealing to us, but of course it also takes some courage to make a system of this kind, basically based on mutual trust, and that courage needs to be present.
Into that, as a system, why do we succeed, are successful on this? I think what we share with the Scottish is that we are small populations. In Denmark, not even 6 million people. We consider ourselves as a tribe. We share the values. We have a very common and a very a healthcare system that is universal, with universal coverage. There's not money between provider and patient. It's tax financed. So we very much share that, and we share the values, the ethical values concerning our healthcare system. Nurses and doctors and anybody else in the healthcare system is unionized in Denmark. 95% are members of nurses organization, doctors association, etc., etc. And we have a very close collaboration in peaceful times with between the employer organization and the employee organizations, and therefore we could very well have the dialogue concerning what is shame doing concerning the progressive work with patient improvement or quality improvement or taking action on mishaps or adverse events. And therefore we on a discussion base we could develop the system, both the patient safety system from the beginning of this century, but as well as improving our health quality improvement system from being this very traditional quality control system, very joint commission like, and onto a much more trustful system. And concerning the leadership program that you asked about, it was really the shared experience that we need to subsidize leaders with some tools where they can work with quality improvement. What kind of tool do you take out of the box to actually get an organization work in a quality improvement setup? And we try to educate them into that, but we do it not taking them out in a seminar for weeks, but make cases, real problems, wicked problems that they have to solve themselves at home, and make a group-wise collaboration from municipality, from general practice, from hospital, in how do we solve this problem, and how do we bring the solutions in home in the backyard afterward. So what is the issue here is to make things very realistic and make it very close to your to the real world, so to speak, to where you are, to what you believe in, what you are dealing with in a normal setting.
Okay, so thank you. There's 2 questions in the chat, so I will be reading them out to you. We first have Nikki Damen. So thank you for the wonderful presentation. I'm highly impressed by what you have reached so far. I'm working for the Dutch National Patient Safety Program, and we are currently struggling with setting up learning quality teams to further improve the themes of our programs. For instance, vulnerable elderly, like you have one program. How were your teams formed, trained? How do you address this in a bottom-up versus the top-down way? That's the first question, and maybe I also will give you the second question directly. Is there any financial support reward based on the results of the quality indicators the hospitals get?
No, to take the last question at first, there's no directly involvement in financing. We think that the entitlements are getting perverted when we do that. It has to be driven by a sincere wish to improve quality. And of course, the payback you got is that if you really are working with your quality and you avoid your mishaps or your adverse events, it will come back to you. We know from OECD reports that adverse events and mishaps would count for nearly 15 or something like of the budget. So there's money in patient safety and in improvement. And concerning the collaborations around the quality and learning teams, learning and quality teams, it's a tough work because you have to, of course, you can get the experts, even if there's many of them, even in a small country. That's one part of it. And they could discuss what kind of quality do we want. We are helped a little here because we have quality databases within each illnesses we have. And we have indicators where we measure the quality and we benchmark quality across hospitals. Or when I say we, they do it themselves. It's the professionals that are measuring and discussing how to do things. So a fundamental thing is that if you want to put up a learning and quality team, you have to base it on good data. The first team we put up with palliation, we didn't have good data, and we invented data to follow during the period that we had this collaboration team, and we realized that if we did not keep up measuring the same thing afterwards, it will quite fall back to where they came from. The culture was so strong that we could not keep the good winnings. So therefore, we'll not implement new measurements, or will not implement new bureaucracy to do those things. So we have to find places where there are an improvement that we want to have, or we want to have more equality in what we do. And as another fundamental thing, we have to have good data that could subsidize the process. And when we do that, we have one region to have the lead, so to speak. They take it in, they manage to do the learning and quality team, they subsidize it, and all parts are involved in it. We some municipalities, some departments, all regions, etc. And then we, with really tough work in the machinery, we work this to get it through over a period of 2 years. And then the really tough thing comes, because when everybody moves back to where they came from, how could we keep the winnings? And that depends on data and strong leadership.
Thank you for this great answer. I'm already convinced. For maybe a last question, there's nothing new in the chat, but I have a last questions for you. Both of you said one of your working points are more integrating the patient's experience, patient's involvement in all your work. How do you imagine it? What are your strategies that you're thinking about to get them involved in this improvement work, learning teams, being in the team and having those patient-centered care, even if we want the patient in the team? Maybe it's not the right vocabulary, but what are your strategies to have those patients, the citizens, the society more involved in their patient safety?
I can speak on behalf of the hospital that we have a whole unit, part of it in my department, where we work with patient involvement on several levels. We started at so many of the very severe decisions that patients have to take through some severe illness. This is an area where one size doesn't fit all. You really have to engage yourself and the departments and the doctors, all the healthcare professionals in this work. So it doesn't come easy, but it's very valuable work. And we have a number of departments in my hospital who are very dedicated to follow this path, to qualify sometimes life-threatening decisions that the patient has to be part of. So, but it's very there are many dedicated healthcare workers who really knows that this is a big issue, and dedicate themselves to this work.
And just for me, we all know the headline concerning patient safety and patient improvement. Nothing about me without me, and what matters to the patient. And that has been so inborn in the Danish healthcare system that we try to sort of implement patients anywhere, even if we have employing committees for new leaders, patients are on board. In steering committees concerning our quality databases, patients on board. And we have panels, patient panels, where departments and hospitals ask them, how do you find, how is our wayfinding? What do you think about our services? Have you good ideas to improve things? And I think what we all have realized is that patients, and we don't even have to educate them very much to be engaged in this, they have so relevant questions. When professors within a specialty is discussing how could we improve this and that, the patient could raise his hands and what does it matter? What is the impact on the patient journey? What does it matter that this screw is placed perfectly in my bone if another part is missing? Information, for example, engagement, asking what is the value for me? And we are very strongly engaging to spread that, so that patients are involved even in when we pick out new research projects. We are putting patient into the committee because sometimes patients has another opinion about the relevant research project than the professor has, for example.
Okay, thank you for this great answer too. What matters to you always works for professionals and for patients. Really great initiatives. So it's almost top of the hour, so I would like to take a moment to thank you all for giving a great speech explaining how you do this in Denmark. I think it has inspired more than one. A lot of great questions too that have enlightened some aspects of your work also, that can give more inspiration again to see how we can adapt and adopt your kind of improvement work that you're doing, adapting it to our culture, adapting to our context, and see how we can create learning and quality teams that will engage in this improvement work to improve quality, patient safety, experience, everything, like you said. So thank you for your great speech. Thank you for everybody who has participated today. Technical aspect, everything will be available online after this webinar within a week tops. So thank you again and have a nice afternoon. Bye.